Well, I just want to, who here is just exclusively doing suprapatellar nails for their tibias? All right, so we have a couple. Who's still doing some infrapatellar nailing? Okay, awesome. Okay, perfect. I think I'm amongst some friends. And Nico, I do remember also reading those instructions at midnight in Houston for the X-Fix. All right, so it's, for tibia nails, it's all about managing the patella. So, I mean, this is a tibia, this is where we want our nail to go. And the problem is, the patella is in the way when we're trying to get our entry path into the tibia. And so we deal with this on the infrapatellar approach by flexing the tibia and then working in front through the patellar tendon. The suprapatellar approach, and so this is again done with the knee hyperflexed. The suprapatellar approach, you go in the trochlear groove behind the patella, and this is done with the knee semi-extended. And so for the infrapatellar approach, you need to have the knee flexed for a portion of the case. And if you have like a tenuous, tenuously held reduction, this could be problematic as you're changing positions a little bit. While as the suprapatellar approach, the knee is pretty much in the same position for the majority of the case. With knee flexion, you're generally more difficult to get an AP and lateral image. It's generally more difficult to get AP and lateral imaging. Although if you have, if you're communicating well with your fluoroscopist, this is usually something that's easily overcome. You may have to manipulate the case multiple times during the leg multiple times during the case. And it's more difficult to maintain a reduction especially for proximal tibia fractures, and then we'll talk about why in a sec, or right now. And that's because with the hyperflexion, you're exaggerating the initial injury deformity. With the knee semi-extended, it's generally easier to get AP and lateral imaging. You're having to manipulate the leg less often during the case. However, in knee flexion, it is easier to impact the fracture to get compression against across simple fractures with the foot planted on the bed. And with the suprapatellar approach, there's a concern regarding intra-articular injury to the cartilage, especially in our younger patients. Attention needs to be constantly given to make sure that the cannula doesn't move, which and sometimes that falls on the assistant. Sometimes it's easy to sort of forget this. So in order to overcome this may involve additional pinning to the femur. Of course, it's more difficult to remove a nail through this approach. So what did like the meta-analyses? So there's so many meta-analyses looking at suprapatellar nails versus infrapatellar nails. These are the ones only from this year alone. In general, looking at all comers for all tibia fractures, proximal, diaphyseal, and distal, the suprapatellar nailing is associated with decreased fluoroscopy time, improved reduction, especially in the sagittal plane, decreased operative time, decreased anterior knee pain. But there's really little that's been shown to be different in terms of long-term knee function. But what about the cartilage? And that's the big concern when the suprapatellar nails were introduced, is you're working through the joint. There have been a couple, small studies. And so this study in 2019 looked at intra-articular damage before and after a nail using intraoperative arthroscopy. Of the 21 patients, again, it was a small study, 17 had no change. Whereas there was measurable or visible chondral injury, grade 1 and grade 2, in a couple of patients. However, these were not associated with anterior knee pains, or functional limitations of the year. Another study demonstrated that 13% of patients had demonstrated grade 2 chondromalacia limited to the trochlear groove on arthroscopic images immediately post suprapatellar nailing, but the MRI findings at 1 year were read as normal. And there's no correlation between the arthroscopic images and MRI findings and patient outcomes. And then there have been numerous a couple different cadaveric studies looking at the contact pressures. So if you have pressures, pressures in front and behind the cannula during a suprapatellar nail, and they were definitely higher than the pressures that you see when you're doing infrapatellar nailing. But overall, these pressures are still below the minimum threshold that's thought to induce chondrocyte death, or that we see with in isolated knee flexions, particularly with going up and down stairs. So suprapatellar nailing, so I've sort of, even though I'm here to sort of defend infrapatellar nailing, I've sort of talked about how it's gives you a favorable position during the procedure. It's easier to maintain the reduction if the reduction becomes tenuous, especially, and this holds true for proximal injuries and distal tibia fractures. We do know that cartilage injury occurs, but it's not correlated with worsened outcomes or long-term outcomes specifically. And there are several. So then why do we consider infrapatellar nailing? And so I take a step back here. And for a nail, in my mind, there are like sort of three critical portions or three parts of a case that really I spend a lot of time on and focus on. One is obtaining that start point. The other one is obtaining the reduction. And the third is maintaining that reduction. And so I think in terms of getting the start point, I do think that even though we have these cannulas, it is a little bit more difficult to get posterior enough on the lateral with the suprapatellar approach because you're being pushed anteriorly. I think, so here you see the cannula here, you're using the eccentric guide to place you posterior, but as soon as you start reaming, you're going to be driven more anterior based on the pressure on the cannula itself. And sort of in this direction. This becomes more difficult, especially in the arthritic knee, in which the patella isn't mobile, or where you have limited patellar mobility, or someone has a flexion contracture. In terms of obtaining and maintaining reduction, I think there is a clear advantage when in the semi-extended approach for proximal and distal metaphyseal fractures. So you see this fracture here, pretty distal at the metadiaphyseal region. And so if I'm having to hold something with a clamp, I don't want to keep moving it because there's a lot of times during the reaming that clamp may get dislodged and I'll need to re-reduce later. So if I think that I'm going to rely on per clamps, then I'll consider a suprapatellar nail. But this is really not an issue for our simple diaphyseal fractures. So if an injury is purely diaphyseal, the infrapatellar nail is really what I go to. The nail is going to obtain your reduction, contrary to like most other fractures. This is probably one of the few times where the instrumentation will actually guide the reduction as long as it's appropriately sized. And so here's a young man who had a simple wedge or a comminuted wedge, but it's in the diaphyseal region. The start point you could get almost exclusively on the AP. If you get a plateau view, you could ensure that you're fine on the lateral and posterior enough. And getting the nail across is what's going to get your reduction and maintain both your length, alignment, and rotation as long as the cortices match up. And then just a short segment on just nail removal. And so this was a patient who had who had this fracture. Given the butterfly and the need for clamps, a semi-extended approach was used. This was a patient with multiple risk factors, went on to develop an infected non-union with a draining sinus. At the time of removal, so regardless of the approach that was used for the initial approach, I'll use an infrapatellar approach to directly visualize the nail and get it to engage for the nail extraction. I think while there are certainly advantages to the suprapatellar approach when looking at all comers, these advantages are really most notable for metaphyseal and metadiaphyseal injuries. And the infrapatellar approach, despite all this, is still my approach, given its efficiency for simple diaphyseal injuries and any sort of revision case, regardless of the initial approach.